Good afternoon, everyone. Thanks for joining us. My name is Ben Duncan, and I'll just do a quick background on me as we dive in. I'm the Chief Diversity and Equity Officer and the Director of the Office of Diversity and Equity for Multnomah County, which is in where Portland, Oregon is. I'm also a founding board member of OPAL, Environmental Justice Oregon, who organizes low-income and people of color to build power for environmental justice and civil rights in the community. Co-chair of the Region 10 Health Equity Council, and I'd like to welcome you to today's webinar from Region 10 Health Equity Council, along with my co-chair, Jamie Lou Delavan. Today's webinar will highlight novel approaches focused on building capacity to address health inequities. We'll hear about the DELTA, which stands for Developing Equity Leadership Through Training and Action Program, which is a comprehensive health equity and inclusion leadership program that strategically provides training, coaching, and consultation to key health, community, and policy leaders in Oregon. We'll also hear about the Idaho Community Health Advisor Program, which applies a culturally specific and trauma-informed approach to increase access to health systems by training refugee community members as health navigators. Now, I'll briefly do some housekeeping points. If you have a question during the webinar, you're welcome to post it to the chat box that you'll see at the lower left-hand corner of your screen at any time during the webinar. These questions will be answered during the Q&A at the end of the presentations. At the conclusion of the webinar, you'll be directed to an evaluation survey, and we'd ask you to please take a few minutes to complete the survey, as we appreciate any feedback you have to help inform future ASTHO webinars. We're also going to include two polling questions as we go through, and we encourage your active participation from all of you. And we will do, if I can figure out the slides, we'll do the first polling question now. And it reads, what resources would be most beneficial for you from a regional health equity council? And this is a live poll, so as you do it, it'll start collecting responses. Webinars and information sharing, successful policy examples, data and research, partnerships, and conferences and convenings. We'll give you a minute or two to fill it out live. Let's take one more minute to get final results. Okay, last chance before we switch out. So we're going to show the results, and you'll see partnerships jumping out. So for the Regional Health Equity Council, and I appreciate all of you who have participated, in this. This is really, for us, meant to guide and get a sense of regionally what folks are looking for in terms of the role of what a regional council can play in this region. So obviously, all of these represent some level of importance for you, but seeing the partnerships and information sharing being the top two, it gives us some direction. In a minute, I'll be passing it over after we do the speaker biographies, and Jamie Lou Delvan, my co-chair, will talk a little bit about the National Partnership for Action and the regional council. So thank you for your participation. So I'd like to, before we dive into the presentation, and a little background on the Region 10 Health Equity Council, I just want to quickly read the esteemed panelists and presenters that we have today. The first speaker we'll hear from is Charniece Tisdale. Charniece moved to Portland in October of 2012 to work at the Oregon Health Authority in the Office of Equity and Inclusion as a Centers for Disease Control and Prevention Specialist. In her role, she coordinates the Developing Equity Leadership through Training and Action, also known as DELTA, Leadership Development Program, and helps provide technical assistance to health-related organizations throughout Oregon. Her previous experiences have included planning, implementing, and evaluating public health research, programs, and community-based initiatives in various settings, including nonprofits, hospitals, and universities. She is a graduate of the University of Michigan School of Public Health. Our second presenter will be Sandra Clark, who joined HealthShare of Oregon's team in 2012 as Project Director for Community Health Strategies. HealthShare of Oregon is the state's largest coordinated care organization, serving over 230,000 people in the Portland metro area who qualify for Medicaid and Oregon Health Plan. She facilitates HealthShare's Cultural Competence Work Group and Health Equity Initiatives and project manages the Coordinated Care Organization's Community Health Improvement Plan. She earned a Master of Public Health from Oregon State University in 2010 and was a 2013 participant in Oregon Health Authority's Developing Equity Leadership through Training and Action program. We'll also hear from Tracy Harrod. Tracy and her family lived and worked in rural Kenya for 7 years. Since moving to Boise in 2008, Tracy has enjoyed the opportunity to serve Idaho's diverse refugee populations in many different ways. She presently serves at the St. Alphonsus Center for Global Health and Healing, where she coordinates the Community Health Advisor Program. This program assists individuals and families being resettled in the United States to overcome linguistic, cultural, and trauma-based barriers in order to access equitable health care. She also serves as an intercultural consultant and provides training across a wide variety of disciplines to help strengthen health and community services to diverse populations. As a Swahili interpreter, she specializes in interpreting for survivors of torture, war trauma, gender-based violence, and domestic abuse. I'd like to now pass it over to my co-moderator, Jamie Lou Delvan. And just quickly, Jamie Lou is the State Minority Health Coordinator at the Idaho Department of Health and Welfare, where she serves as Cultural Liaison and Cultural Competency Guide for Health Promotion and Chronic Disease Programs. In 2009, Jamie initiated a project with International Rescue Committee and Idaho Women's Network, where she co-authored a Refugee Rights and Responsibilities program covering American culture, law, education, healthcare, and social services. She is currently developing a WISE Renter program for immigrants and people experiencing homelessness. Jamie Lou is also the co-chair of the Health Equity Council for Region 10, and I'll pass it on to her.
Good afternoon, everybody. I just want to quickly go through before our presentations, because I know we're all waiting for the presentations, but I want to give you a tiny bit of background about the National Partnership for Action to End Health Disparities. Go ahead in the next slide. I don't have control over my slides, so you'll hear me say next a little bit. The National Partnership for Action to End Health Disparities is a national movement that's facilitated by the Office of Minority Health. And the purpose is to increase the effectiveness of programs happening across the nation in different regions and to mobilize partners and leaders and stakeholders with the goal of eliminating health disparities. And often we're bringing together leaders that may not have been collaborating in the past, but are still all working on issues that impact health and especially health disparities. This movement, this initiative, the MPA, is broken out into 10 regions. So there are 10 regional movements called RHECs, or Regional Health Equity Councils. Thank you. And each council has come up with their own action items depending on the region and mobilizing in that way and leveraging federal, regional, state, and local resources, all with the purpose of infusing MPA goals and strategies into policies and practices. So each region is a little bit different. Obviously, our nation is very different. And we aim to share information such as through this webinar and successes and promising practices throughout the nation. Next slide. And there's just a pictorial example of where the 10 regions are. So we are presenting from Region 10, Washington, Oregon, Alaska, and Idaho. Next slide. So the RHEC common priorities, which are the MPA priorities, are building communication and capacity, developing membership, partnerships, and champions, improving access to quality care, identifying intervention points and developing tailored strategies, cultural and linguistic competency, education and training, and improving data collection, usage and reliability, and disseminating that data. Next slide. The Region 10, each region obviously has their own vision and mission. They're very similar. Our vision is to see a nation free of health and healthcare disparities, and our mission is to identify efforts and resources in the region that target the elimination of health disparities, promoting health equity, and educating and increasing awareness of social determinants of health within our region. Next slide. Our primary priority areas are to increase plain language health equity communication and outreach efforts, enhance our membership to continue to diversify it from fields and different backgrounds, and enhance our diversity in the workforce. Next slide. When we were preparing for this webinar, we were thinking about different examples of things that were happening in the region, and we really wanted to look at we decided to bring in two different approaches. One is from more of a training around policy and program decisions, and the other impacts more at a local level clinical services. So there are two very different approaches to address health inequities and health disparities in the region. Next slide. So we come to our next poll. Are training models an integral part of your organization's strategy to address health disparities? Go ahead and take a moment to answer yes, no, or I don't know, you're not sure. Okay, and I think we're just about ready. Do we have our results? Okay. So with that, we're going to segue into our first presentation. And our first presenter is Charniece Tisdale.
Thank you. Good afternoon, everyone. Again, my name is Charniece Tisdale, and I am the Program Coordinator for the Developing Equity Leadership Through Training and Action, or DELTA program. Joining me on this call is one of our wonderful pilot cohort participants, Sandra Clark, who will talk about her experiences in the program later in this presentation. And I just want to say that it's exciting to see how many people are using training modules in regards to eliminating health disparities based on that poll. All righty. So now I want to get into the goals of this presentation. Here's what we're hoping to achieve for today. I want to provide an overview of the Oregon Health Authority, Office of Equity and Inclusion, also known as OEI. I want to share OEI's innovative practices for developing health equity leadership through the DELTA program, and also discuss experiences of the DELTA program from a participant's perspective. So first, let me talk a little bit about OEI. OEI's vision statement is all people, communities, and cultures co-creating and enjoying a healthy Oregon. Our mission is to engage and align diverse community voices and the Oregon Health Authority to assure the elimination of avoidable health gaps and promote optimal health in Oregon. There are 3 units within OEI. They are equity, diversity, and administrative. As you can see in the presentation on the slide, we engage in various activities, including policy development, community engagement, strategic communications, recruitment and retention, as well as data improvement. The DELTA program is housed in the equity unit under community engagement. So what does DELTA stand for, and how does it play a role in advancing health equity? Developing Equity Leadership Through Training and Action is a health equity and inclusion leadership program intended to convene a cadre of leaders who will in turn directly impact issues, structures, and policies around health equity. The original concept of the program came about after noticing a gap in need for training, technical assistance, and practical implementation of health equity, diversity, and inclusion strategies in public health, healthcare, community-based, and other related organizations and institutions across Oregon. To date, there have been 2 cohorts of the DELTA program. The first cohort was piloted in 2013 and funded by a Kaiser Permanente Community Benefits Grant. Upon conclusion of the pilot program, OEI received funding from the Centers for Medicare and Medicaid Innovation, otherwise known as CMMI grant, for 3 additional cohorts. We are in the process of wrapping up the second DELTA cohort in September, and we will begin our third cohort in January 2015. The program is comprised of full-day classroom-based training, supplemental tools, materials, and resources, project management, and coaching and technical assistance. Our first cohort was comprised of 18 participants who met once a month for 6 months. They received technical assistance and were involved in a large-scale evaluation. Our second cohort, which is our current cohort, has 23 participants, and they meet once a month for 9 months. They also do technical assistance, and we involve evaluation, but in addition, they have a project component so they can actually practically apply the things that they are learning. Past DELTA topics have included health literacy, language access, leadership for health equity, race, ethnicity, and language data, and health equity metrics, diversity in recruitment, hiring, and retention, and more. Our trainers consist of local and national subject matter experts. We have had dynamic trainers come as far as from the National Health Law Program in Washington, D.C., to Kaiser Permanente in Oakland, California, and right down the street at the Multnomah County Health Department in Portland. When selecting participants for the DELTA program, we seek diversity in racial and ethnic background, gender identity, sexual orientation, organizational type, and job position in order to achieve a well-rounded and inclusive experience. In regards to professional makeup, a large percentage of the DELTA participants identify themselves as program managers. However, there are a variety of titles, including a Senior Director of Clinical Services, Director of Child and Nutrition Program, Maternal and Child Health Policy Specialist. We have a Chief Health Strategy Officer, Manager of Diversity and Civic Leadership, health equity officer, language access supervisor, associate professor, and more. Many of our participants are from community-based organizations and nonprofits. However, several are also from coordinated care organizations, health systems, and local, county, and the state health department. Since health disparities are intricately linked to social determinants of health, we have also included members from the Department of Education, behavioral health organizations, housing, and foundations. Most cohort members work in the Portland area, but we have made a concerted effort to diversify geographically. For example, this year's cohort has 13 Portland-based participants and 10 members from cities outside of Portland, such as Ashland and Eugene, Oregon. As part of our recruitment strategy, we like to host informational sessions. This year, we will be traveling to rural areas throughout the state to conduct targeted outreach. It's important to note that this program is not designed exclusively for health equity experts. This program is intended to enhance the knowledge and skills of anyone interested in advancing equity work at a systemic and institutional level. So I just wanted to show a few images of what a typical Delta training looks like. And so as you can see in the presentation, we have lots of group discussions as well as games, brainstorming, people take notes, and yeah, we have speakers, so the didactic part of the training. It's a variety of techniques for adult learning. So now I'd like to take a step back and talk about the overarching goals of Delta. In other words, what we hope this program achieves. The goal is that by the end of the program, Delta cohort members will become equity change agents through partnership engagement, enhanced knowledge and skills, project implementation, and strategic planning. More specifically, we hope that the cohorts will act as drivers and enablers of an equity and inclusion agenda within Oregon's public health and healthcare systems, as well as facilitate the development and institutionalization of health equity and inclusion strategies in their own healthcare and public health settings. Now I would like to turn it over to Sandra Clark, who was a member of our pilot cohort and now currently a member of our alumni network. She will talk about her learning experiences in the program, as well as how it translated into the work that she does currently for HealthShare Coordinated Care Organization.
Thanks, Charniece. Well, I just wanted to start out by saying that it's just such a great opportunity to have a few moments to reflect with everyone participating in this webinar on the impact that the Delta program has had on me and by extension on my work at HealthShare of Oregon. When I joined the Delta program in 2013, I think I really kind of fit into that description Charniece just went over of someone who, didn't have very much specific training in health equity and analyzing health disparities beyond kind of the bedrock foundational work I did in my public health program and being exposed to the health equity and empowerment lens through Multnomah County Health Department in a previous position. And I didn't have a high comfort level with kind of embracing the role of health equity and eliminating health disparities in my own job at HealthShare, where we are tasked with providing care and services and improving outcomes among over 230,000 people on Medicaid here in the Portland metro area. And our membership is more than 50% people of color, and we have over 100,000 members who require health services in a language other than English. Yet for various reasons, in a lot of the foundational plans for Medicaid and the Oregon Health Plan, eliminating health equity, eliminating health disparities, and promoting health equity usually comes as an add-on to the triple aim. And in my position, I really needed support to take things to the next level and bring that up. And that's where my experiences in Delta really impacted me. And so when I was thinking about my learning experiences, I really sort of break them down into some very tangible and specific valuable outcomes and others that are less tangible. And just like the first polling question we had, we saw that most people value partnerships from a regional health equity council. probably the biggest value was developing this network among the cohort of individuals that I was able to work with and bond with and get to know as we went through this 6-month journey together. And that network has been really powerful for me in the long term. I think one of the really valuable approaches that the Office of Equity and Inclusion here took with developing the Delta program was creating a safe space in the training program to where we were all there based on our roles in our organization. We were there, acknowledging that we have a role with the state or with a health system or, with a particular program goal. But what our trainers really worked to do was emphasize our skills building as individuals. And from the very first session, they emphasized how this work is the work of a career, and we will move into different positions over our lifetimes, but that as Oregonians that we're coming together to form a long-term network and cohort of individuals committed to developing our leadership and committed to doing this work together over time. Because as we know, this movement to promote health equity and truly eliminate health disparities is a long-term project. It's not something that you check off, and I think sometimes we're working for organizations where we have pressures either because of grants or timelines that kind of prevent us from thinking with that long-term goal, especially in the context of our own individual lives and our roles in the community. And also as a white ally, gaining that identity was really important. And then in terms of what happened over the next 6 months was that we were exposed to really amazing trainers and provided tools, including learning about different approaches to framing health equity and understanding what healthcare disparities are and understanding how you can talk about health disparities and then link them to actual healthcare disparities, which turns out to be really important in my work, working for a Medicaid plan, where our responsibilities tend to be on the health outcomes. And sometimes it's a little hard to locate the organization's role in eliminating broader health inequities that we link to the larger social determinants of health. The enhanced class standards, culturally and linguistically appropriate services standards, were newly released in 2012. And the Delta program invited Ignatius Bow from Washington, D.C., who had a role in developing those enhanced standards. And he came to us in the capacity of a consultant, which was kind of great because he wasn't there necessarily representing the Office of Minority Health, but as an individual. And so he was able to highlight the improvements to the class standards, but also discuss how there's still room to grow and there are things that we need to do, and that as individuals and as change agents that we can use the class standards, but take them a next step further, kind of recognizing that things change incrementally. And on the less tangible side, it's not a typo that I repeated developing a network. And in the last session, Ben Duncan, our moderator here for the webinar today, was one of our trainers, and he presented on Multnomah County's health equity and empowerment lens. And toward the end of his presentation, he said something that has stuck with me and really had an impact on me, which was to say that as individuals doing this work, we should think of ourselves as an organization or a nonprofit, which always has a board of directors. And that the role of that board of directors is to help steer the organization, to ensure its stability, ensure its long-term health. And he encouraged all of us as we move forward to think about who would we have on our board of directors as change agents promoting health equity and eliminating health disparities. And I have been actually written down my list, and some of them might not know it, but I have a board of directors. And so that was a more kind of a less tangible thing in terms of thinking about my network of people that I'm working with, but also reaching up and out to people that I want to be like and emulate and learn from. And again, it also promoted a lot of internal exploration, emphasizing how this isn't just about your job, but who are you in your community. And this is how I would just describe that it's had a long-term effect. And I think part of this derived from the format of the training, which I think shouldn't be overlooked, which was to give us a full day once a month and then come back month after month. And it gives more of an opportunity for the learnings to sink in and for us to reflect. And to tell you the truth, I strongly feel that the impacts of Delta on me have really been more about what's happened in the year after I took Delta. Like, it really had this long-term kind of sinking in. And just a couple minutes on how I've applied the skills. We at HealthShare are a collaborative of many different organizations, managed care, hospital systems, and we face the challenge of organizing a systems-level approach to establishing measures for improvement. And I helped form an organizational assessment that consisted of 5 sections that I based on the new class standards that we conducted over the last year. And the way that we did that was through convening a cultural competence work group, which I facilitate. And one of the effects of Delta was that I kind of found my voice and found my role in helping create a similar safe space for the leadership, people representing their organizations, leaders coming together through this work group to not do things that made identifying gaps seem like we're auditing or trying to be critical, but that we're identifying gaps so that we can see where the real opportunities for making tangible changes are. And we also, as a CCO, have a requirement to conduct a quality improvement plan focused on disparities. And I was exposed to a lot of national resources, including the National Quality Forum's work on identifying disparity-sensitive measures. And that probably helped me overcome what may have been hours of extra work or going down the wrong paths. And so we were just really given a lot of resources that helped me apply them directly. And now the Oregon Health Authority's Transformation Center, which supports our CCO and the other 16 coordinated care organizations throughout Oregon, we're establishing a health equity learning collaborative that Charniece is also providing technical assistance for to help all of us in the CCOs focus in on the opportunity for promoting health equity. And finally, one of the best outcomes from my point of view is how, since finding my voice and having the support from the state with this Delta program, we have included cultural competence and health equity as a foundational strategy at HealthShare, in addition to our strategies around the triple aim. And our CEO and our leadership executive team have really embraced health equity and disparities. And I think one of the reasons why that has happened is just because of the leadership of the Oregon Health Authority, including this Delta program and the support that we've received over time. So thank you.
Okay, and so I believe we're going to get to questions at the end of the program, but here is my contact information. And now I would like to hand it over to Tracy Harrod.
Thank you. Good afternoon, and thank you everyone for listening in. I'm Tracy Harrod. I work as a coordinator of the Community Health Advisor Program and also as an intercultural consultant at the St. Alphonsus Center for Global Health and Healing in Boise, Idaho. And I'm going to be sharing with you this afternoon a sort of a specific example of a community-based service model, which also serves as a training model for our entire community, really. This is a relatively new program. We've just been actually officially operating for a little over a year. So I'm just going to tell you a little bit about the foundational principles around which the program is being developed and how the program is seeking to train the community inequities through modeling. And also just sort of, since we're a relatively new program, some of the things that we're noticing and learning so far. The community health advisors are the key in the center of this program. And they are multicultural, multilingual individuals who are trained to assist individuals and families who are resettling in the United States as refugees to navigate the healthcare system. So community health advisors, or CHAs, are seeking to decrease health inequities by increasing access to culturally responsive, linguistically appropriate, and trauma-informed healthcare. They do this by serving as cultural mediators and care coordinators. So community health advisors are members of a patient's own culture and language group. Because of this, we think that they are uniquely qualified to be trained to reduce barriers to healthcare by helping to navigate the healthcare system. So they're seeking to reduce health inequities by increasing access to trauma-informed, culturally responsive, and linguistically appropriate care. They're providing training to both providers and patients by serving as cultural mediators. So this is a pictorial example of the model that we use both in training community health advisors and also as we have opportunities to train healthcare providers in our community about partnering with community health advisors in order to reduce healthcare inequities. We call this the equity triad, and this is just something that we've developed because we feel like the 3 points that are represented here are really sort of the foundational principles that we need to focus on, because these are the 3 areas that we need to adapt services in order to provide equitable care. So that the 3 areas are trauma-informed practice, and that is one of our foundational principles, because for so many members of diverse populations who are immigrating to the United States, whether that's with refugee status or other forms of immigration, trauma is pervasive for these populations, and so in order to be providing equitable care, we've got to be adapting our services to be trauma-informed. Also culturally responsive, because obviously we're dealing with diverse populations and diverse cultures, and then linguistically appropriate. So these are the 3 things that we focus on. The reason that we believe CHAs, or community health advisors, are uniquely able to increase access to trauma-informed practice is because, first of all, they usually understand the patient's trauma history better than we could, better than any of us in the provider, service, or care position could, because this is a member of the patient's own community, possibly has a similar trauma history themselves, or at least are very aware of the historical trauma that's involved with their population group. Also, community health advisors are able to recognize trauma and stress reactions that might be causing trust issues that are making it difficult to provide quality care and good health outcomes. A lot of times what we perceive in a patient that might appear to be something like resistance, or what we typically call non-compliance in healthcare, is actually a trauma or stress response, and the CHA is able to recognize that a lot of times and therefore reduce the inequity that sometimes happens as a result of that. CHAs can assist the provider to restore dignity and respect to a trauma survivor through the appropriate use of greetings and titles. And this is an example of one of the ways that you'll see the 3 circles that represent our 3 foundational principles there, how they're sort of interlinked. And the reason that we've devised this model this way is to show that these things really, the 3 of them, cannot be separated. They're all constantly interacting with one another. So for example, a cultural issue such as not being able to provide a respectful greeting to someone who, through their cultural lens, would make them feel safe and be able to establish trust with a provider, if there's a lack of dignity and respect in the room, then that could actually cause a trauma response. And so that's an example of how these things interact with each other, and that's something that really a CHA is uniquely able to help us with. A CHA can also establish safety and trust for a survivor by monitoring environmental factors and explaining what will happen next. So for example, in a room that's a very small room, maybe the door is closed, maybe there are no windows, maybe the provider is seated between the patient and the door. This can be an environmental factor that can be a trauma trigger for a survivor. And those types of things are things that a CHA can recognize and help to navigate so that we can provide better health outcomes. Also explaining what will happen next. A lot of times this is very important for trauma survivors. to be able to feel some power and control by knowing what's happening in a medical system that's very different from anything they've ever experienced before. And also, a CHA can advocate for a trauma survivor's need to have choice and voice in every medical encounter. For trauma survivors, during their traumatic experience, power and control is stripped away from them. And so in order to establish a trust relationship with a provider, they have to be able to feel like they are able to have a voice and able to be in control of being a partner in their own health care. And a lot of times those things are missed for us because we don't understand the cultural lens through which they're viewed, and the CHA can really assist us in that. CHAs also assist us in increasing access to culturally responsive practice. This obviously is a great need of ours because the only person who's an expert in their own culture is that person themselves. And particularly as our patient populations are getting more and more diverse, it's going to be impossible for us to know what are appropriate cultural responses in every encounter. So we're going to really need to be depending, I think, more and more on people who are insiders in culture and language groups to guide us in these things. So a CHA serves as a cultural bridge who is trained to understand the cultural lens of both the provider and the patient. With the patient's permission, the CHA can explain cultural and religious factors to provide better health outcomes. A lot of times there are things that are just being misunderstood. Maybe the patient doesn't feel comfortable to speak out about them, and those are things that can greatly affect health outcomes, and sometimes we're not even aware of it if someone doesn't point it out. A CHA can also help to dispel cultural stigma that surrounds certain conditions, illnesses, and treatment methods within the patient's cultural viewpoint. Sometimes, again, these are things that a lot of times aren't even voiced to a provider, so sometimes a patient will have difficulty following through with treatment or taking medications due to the cultural stigma that they're experiencing, and it's not being addressed sometimes because no one knows about it. But a CHA would be someone who would know about that and be able to address it. And also CHAs provide home visits and other culturally appropriate avenues for building trust between the patient and the healthcare system. We're finding this to be really important, that as a patient a lot of times, especially if they're a relatively new arrival in the United States, their health advisor might be the first person that they really feel comfortable with and trust that's related to the healthcare system. So we try to really encourage that trust, and then the CHA is able to transfer that trust to the provider and to the healthcare system, building a bridge that sometimes we wouldn't otherwise be able to bridge and enabling us to reduce health inequities. And then the third area, let me go back to the proper slide there. The third area is in a linguistically appropriate practice. A lot of times we assume that if we just have an interpreter present that we are providing linguistically appropriate care, and a lot of times it's actually more complicated than that. And a CHA is someone who can be aware of all the intricacies of providing linguistically appropriate practice so that we are reducing barriers rather than increasing barriers. A CHA can ensure that a patient understands their treatment plan, medication, and other instructions because they obviously are a person from within the patient's own language group. They understand and advocate for the details of a patient's linguistic needs, such as dialect specifications, gender issues with an interpreter, ethnicity issues with an interpreter, some of those specific issues that come up with interpreters that we're usually not aware of, but that might actually prevent a trust relationship from being built. And of course, if there's no trust in the encounter, health outcomes are not going to be good. CHAs can also assist with interpretation and translation for pharmacy needs. Usually the pharmacy is a place where there isn't a lot of interpretation and translation provided, which you can imagine, of course, is a big factor sometimes in health inequities. So if needed, the CHA can translate medication instructions into the patient's language or use picture-based instructions for folks who are pre-literate. And a CHA can assist with phone communication with providers, such as making or rescheduling appointments. Because it's one thing to have interpreters at a medical encounter, but what about those phone calls to make an appointment, reschedule appointments, the phone calls that come from the provider's office about an appointment? There's obviously a language issue there. So CHAs can also help with those language issues that tend to sort of fall between the cracks. So these are the three important foundations that we try to focus on because we believe these are the three areas where services need to be adapted the most in order for us to provide equitable care. If we're paying attention to trauma-informed practice and culturally responsive practice and linguistically appropriate practice, and we're noticing that we're having great response from patients who have a community health advisor, and we're able to make a lot more progress in making sure that these three areas of service are being adapted with the assistance of a community health advisor who is able to be that cultural bridge. CHAs also reduce disparities by seeking creative solutions to transportation and financial barriers. A lot of times people are not accessing healthcare just due to transportation barriers and not knowing how to seek creative solutions for that. And then of course, obviously financial barriers, knowing what resources are available. CHAs also assist with care coordination in those ways. Coordinating care between multiple providers. A lot of times people are not receiving quality care because they're needing a lot of specialty appointments, and it's very difficult and overwhelming for them to be managing those specialty appointments or even making the appointments, finding transportation to them. That's where health inequities sometimes come in, and CHAs can assist with that. Also connecting patients with resources for addressing social needs, because it's very difficult sometimes for patients, especially trauma survivors, to even focus on caring for their own health care needs when there's a great social need that's right in front, right on top, and that's the thing they're focusing on. So CHAs also can connect patients with resources such as social work, people who can assist with housing needs. They can help with health and welfare and filling out forms, applying for assistance, those kinds of things, so that patients can better focus on their health care needs. And also CHAs can and do participate in community-based training for care and service providers. So they're able to give feedback at various clinics, mental health clinics, TV clinics, primary care providers, where they're able to give community-specific or culture-specific feedback to providers that enable the providers to give more culturally responsive and trauma-informed care and information to their patients. So I'll just leave you with a little bit of information about the very short history of our program development so far. We began in November 2012 with funding provided by the Schwartz Center for Compassionate Healthcare in collaboration with the Idaho Department of Health and Welfare Refugee Program. We piloted for a few months in 2013 with just one community health advisor working with a small group of elderly Burundian patients, and then we officially launched in May of 2013. We now have 9 community health advisors working in 15 different language groups between them. We currently have 6 primary care clinics that send patient referrals to us, so patients are referred to us by primary care providers. We have about 76 current participants, patients who are participating in our programs. And in the first year of operation, we had 575 CHA-assisted appointments. And we have a long way to go in collecting data since we're a new program, but here's one that we've noticed so far. One of our clinics that is probably provides the most referrals into our program. The average no-show rate of that entire clinic, all population groups, is 22%. For CHA program participants at that clinic, the no-show rate, including primary care, specialty, and mental health appointments, is 4.96. So we're seeing that at least we're helping patients to access better by getting them to their appointments. So thank you very much for your time today, and here's some contact information for me if you have questions.
Great. Thank you to to all of our presenters. Very informative and certainly inspiring. I'm imagining a standing ovation, but we'll have to use our imagination. The operator, as we go into the Q&A part of this webinar, if you could just give some brief instructions on how to call in with questions, because that's also going to be an audio option as well.
Certainly. Ladies and gentlemen, if you would like to register a question, please press star followed by the 1 on your telephone keypad. If your question has been answered and you would like to withdraw your registration, please press the pound key. One moment for your first question.
Well, and we actually had a couple questions in the chat that are really quick. So for the Delta program, if you can clarify what the age demographics are. And I think the question was really related to whether there's an option for youth participation in leadership development. So if you could just kind of quickly answer that.
Okay, thank you, Ben. So in regards to the age demographic, we don't have any exact numbers, but most of our cohort members are working professionals, so I would assume 21 and up. We do not engage high school or undergraduate students in this process just because we're really focused on making change in organizational settings. Not to say that that can't be something that's done in the future, but right now we're really focused on systems and strategic planning and outcomes at the organizational level. And so that's why we haven't really engaged with younger participants at the time being. Thank you.
Thank you. And I saw that question came from Ani Mechi, so maybe that the youth leadership program could be something that gets developed out of Office of Minority Health. For the second question, it's a really, I think it's maybe a quick clarification around two things. One, is there a difference between a community health worker versus a community health advisor? Is there an actual difference in kind of work and a difference, or is it a language choice? But also, are they paid?
Yeah, thank you. Both important questions. Yeah, a community health advisor really is very similar to a community health worker, and in fact, our model is based similarly to a community health worker model. I think the important thing that's specific to this program is that they are is that the CHAs are drawn from within the patient's own population group. So in many community health worker models, that wouldn't necessarily be true. But yeah, basically, this is a culture and language specific community health worker type program. So I hope that clarifies that a little bit. And yes, they are paid. And they're not, I noticed someone else had a question about Medicaid here. So yeah, their services at this point are not covered by Medicaid. We have, that's paid through our funding, which comes through Idaho Department of Health and Welfare. So they are paid as contractors by the hour.
Great, thank you. We were going to go back and forth, but it looks like Jamie Lou is telling me that she can't see the questions. This is probably for both of you, and realizing it's probably a deep question, but we'll try to have a quick response. What has been your biggest challenges in implementation of these two programs? So maybe starting with Delta and then going to immigrant and refugee work.
So the biggest challenges with implementation, I would say, especially for our pilot cohort and our pilot program, there wasn't necessarily a guide for us. We kind of just explored it as we were going along. We convened the Delta Advisory Committee, which definitely helped within the guidance of developing curriculum and needs assessment and evaluation plan. But I think starting from the ground up, just trying to figure out what this program is going to be and how it's going to be implemented was the biggest challenge, as well as meeting the needs. We have a very diverse cohort. We do have a very diverse cohort currently, and just trying to meet the needs of everyone, particularly how you can address a topic within like a coordinated care organization versus a very small community-based organization. So we really try to blend topics and experience to come up with a really holistic curriculum, but sometimes that doesn't work out, but that's what we try to do to accomplish that barrier. I think that's the biggest one.
And Tracy?
Yeah. Long question, but I'll give a short answer. Yeah, I think one of the main challenges for us has been that we're not aware of a really lot of models that are similar to this one. So there's been a lot of program development where we're researching and finding everything we can from similar models, but really kind of needing to do a lot of the development ourselves and coming up with our own training model for training health advisors, and also obviously a very multicultural group of people. So that's been both the challenge, I would say, and also the joy and excitement of this program.
Great. And it looks like we had a question, and I don't know if it's who it's directed to, by Mei-Chi Yang, it looks like. What's the best way to share the curriculum or guide? And I don't know if this is probably for Delta, but I don't know if there's a similar response to that for you, Tracy. So what's the best way to share, Charniece?
By personally contacting me or visiting our website. If you just Google Oregon Health Authority Office of Equity and Inclusion and then search Delta within that, you can find our website, and it should have our curriculum and our bios and all of that information. But if you want more detailed information about the actual planning process, then you can contact me directly.
And Tracy, I don't know if there's a guide for what you're doing, but for folks that are attending, these slides will be available afterwards that have the contact information for our presenters. Is there any phone questions to the operator?
No questions at this time.
Great. And I see Tina Harris. Traditionally and predominantly, community health workers are from the community they are part of and trained to work within their community. So, Tracy, I don't know if you have a distinction. I think the statement you made was that these are folks that are kind of coming out of that community or within that community. So I don't know if you have a response or thought around maybe a deeper clarification around the difference that you were trying to articulate.
Yeah, thank you for the opportunity to clarify that and for making that point, because obviously, again, this is a type of a community health worker program. It's not officially a community health worker program, but it's a very similar model. And I think the important point for us in this model is that since it's a program that's designed specifically for populations of people that are resettling here as refugees, what we're trying to do specifically is bring folks into the program as community health advisors that arrived in this country as refugees themselves, so that they're able to really share in that experience, and particularly the trauma experience of people from within their communities. But yes, very similar to that, and in that community health workers are coming from the community that they're a part of.
Great, thank you. So it looks like we're right about the time. I'm going to move us. I don't see any other questions coming in. There's an evaluation that will be coming up at the conclusion of the webinar, and we really would ask that you take a few minutes to complete the survey. It really does impact for ASTHO and also for the RHAC as we think about doing more of this type of information sharing in the future. So if I don't see any other questions pop up, I think you'll be redirected to the survey, but I want to just give one last moment of appreciation for all of our presenters, for the wonderful questions and clarifying questions that folks put out, and for everyone for attending in this very important and critical work that we all are invested so deeply in. So thank you for participating.
I'd also like to thank the Office of Minority Health for helping to sponsor this along with ASTHO, and to let you all know that there will be a recording of today's webinar available on the ASTHO website within the next few days. So I think that website will probably come up on the screen shortly. Thank you, and enjoy the rest of your day.